you so much for that wonderful introduction, Rosa. Good afternoon, everyone. It is an absolute honor and pleasure to be here. As Rosa mentioned, my name is Tolu Oyesanya, and I'm an associate professor in the School of Nursing at Duke University. I'm joined by two of my team members today, Maraliz Mercado Emerson and Mariela Hernandez Jaramillo. We are here to talk with you all today about an ongoing project that we have. We're conducting a study that is aiming to support the transitional care needs of patients with traumatic brain injury and their families who speak Spanish. And so we will do some introductions and then we'll get started. I've already introduced myself, but I will add that I'm the principal investigator of the study. Next, Maraliz will introduce herself.
Hello, hola, I am Maraliz Mercado Emerson. I have been at Duke for 15 years, so this year I celebrate my quinceañera. Um, and I am one of Tolu's clinical research coordinators for the Better study.
Thank you so much, Maraliz. Mariela?
Hola a todos. My name is Mariela Hernandez Jaramillo. I'm the other clinical research coordinator on the study. I'm pretty new to the study. I've only been here for a month, but still learning, still growing, but excited to be a part of this team.
Thank you so much, Mariela. Next, we would like to share acknowledgements for our team, as we could not have done this work without a long list of individuals who have supported us over the years. We have multiple researchers, investigators on our team that have supported us, study staff, as well as healthcare providers at Duke University Hospital and the wider health system. We've also been blessed to receive research funding from the National Institute of Health, and we have many research participants who have graciously participated with us in this study. We actually have some other team members that are on the call today that I would just like to briefly introduce themselves. Stephanie Ibemre, would you like to introduce yourself?
Sure. Muy buenas tardes a todos. Espero que ustedes están muy bien. Soy Stephanie Bemery, soy una profesora en la Escuela de Enfermería y soy co-investigadora con Tolu en este proyecto. Muchísimas gracias por el tiempo hoy. Gracias.
Thank you so much, Stephanie. Anne, are you available to introduce yourself?
Absolutely. My name is Ann Piopo. I am one of the transitional care managers on the study as well. Welcome to all. Thank you for being here and listening to our talk.
Thanks so much, Anne. And Rosa Gonzalez Guarda, I think I just saw you join. Are you available to introduce yourself?
Yeah, saludos a todos, everyone. Rosa González Guarda, I'm one of the co-investigators on the study.
Thanks so much. Any other team members on the call? Wonderful. We'll continue on. Again, everyone who has participated on this study has made significant contributions. We could not have done this work without them. So we always like to start with kudos to our team and thank them for their support. So next, we're going to give you some information about traumatic brain injury to help with putting things into context. Traumatic brain injury is defined as a bump, blow, or jolt to the head that disrupts the normal functioning of the brain. Each year in the United States, more than 2.7 million people sustain a traumatic brain injury. Traumatic brain injury is also very expensive, costing the US healthcare system over $76.5 billion each year on the part of treatment alone. In addition, there are over 5.3 million people who are living with the chronic disabilities caused by TBI. TBI can be characterized as mild, moderate, or severe, with more severe injuries causing worse impairments in cognition and communication, physical functioning, psychosocial, or emotional functioning as well. Many of these impairments are acute and chronic, meaning that they last over the patient's lifespan. When we take all of these things together, these impairments can cause a loss of independence on the part of the patient, which can have a significant influence on the family especially as it relates to the support of the patient after they go home from the hospital. Research on racial and ethnic disparities in traumatic brain injury show that our Hispanic and Latino patients have worse outcomes compared to non-Hispanic white patients and their families. This is demonstrated by higher rates of hospitalization, more severe injuries at the time of discharge, worse physical, mental, and social outcomes, higher readmission rates, long-term disability, depression, substance abuse, and unemployment. Overall, these issues cause a higher need for care, but unfortunately, there are less resources to access for our Hispanic Latino patients with TBI and their families, especially those that are Spanish speaking. And all of these issues result on more reliance on the family for support. Now, we conduct research on transitional care. Transitional care is defined as actions in the clinical encounter that are designed to ensure the coordination and continuity of healthcare for patients transferring between different locations or levels of care. The transition that we focus on is the transition from acute hospital care to home. There is limited research on transitional care specific to traumatic brain injury. However, the existing literature does show us that patients and their families are really struggling after injury. They are having a difficult time as they return home from the hospital. They're having difficulty going to follow-up appointments and navigating the healthcare system. And our research shows that they want more support from healthcare providers as they transition home and in the several months after discharge. Unfortunately, though, there are very limited TBI transitional care programs available to support patients and families. This might be due to the fact that there are no US standards for transitional care for patients with TBI. In addition, the few existing TBI transitional care programs are actually not effective, for racial and ethnic minorities. The existing programs also do not incorporate family or focus on quality of life. There are also barriers to participation for Spanish-speaking patients with TBI and their families in the few existing programs. First and foremost, there have not been participation of Spanish-speaking patients and families in these interventions, meaning that their needs and preferences were not captured in the development of the intervention or the testing of the intervention. Many of these programs are not culturally or linguistically adapted. We have challenges with accessing interpreters, both in the healthcare system and definitely for research purposes. And again, all of these challenges limit Spanish-speaking patients and families' ability to benefit from these programs, and again, increases the burden on family. And so these ongoing disparities led our team to develop the Better TBI Transitional Care Program. What we're going to do next is walk you through the program. We'll tell you about the components and the research that we've done so far to test the program. So the name of our transitional care program is Better. Better stands for Brain Injury Education, Training, and Therapy to Enhance Recovery. Better is a patient and family-centered behavioral transitional care program for patients with TBI who are discharged home from acute hospitals care without inpatient rehabilitation or transferred to another location or level of care. So this means that they're getting care at Duke University Hospital and then going directly home without going to any other setting or hospital. For the intervention, for the program, we have transitional care managers who are healthcare providers with experience caring for neuro or trauma patients. And these transitional care managers are assigned to work with a patient and their family member in the program. Here are the 6 components of the program that the transitional care managers deliver. The first component is assessment of patient and family needs and referral to community-based resources by phone. So we work with the patient and family on an intermittent basis. Initially, we start working with them at the very least once a week, and then we move to working with them about twice a week over a 4-month duration. We have a long list of needs that we assess that I'll show you on the next slide. And depending on their needs, we provide them with referral to community-based resources and services that are local to where they're living. The second component is patient goal setting and review of goals over the phone. So before the patient leaves the hospital, the transitional care manager talks to the patient about what goals they have and things that they'd like to improve upon by 4 months post-discharge. And then the transitional care manager regularly assesses these things with the patient and refers them to resources to help them in achieving their goals. Our third component is healthcare coordination by phone. So often this is scheduling, rescheduling, confirming appointments, but it is also updating the patient's primary care provider about the patient's injury and their needs. If the patient does not have a primary care provider, we help them to establish contact with a new primary care provider and help them to schedule appointments. Our fourth component is availability by phone. So the transitional care manager is available by phone to answer questions that the patient and family have. We view the transitional care manager as the central contact for the patient. And so any health-related questions they have, they can reach out to the transitional care manager during business hours to answer those questions. And if the transitional care manager does not have an answer, they are tasked with finding an answer and getting back to the patient and family. We do this so that the patient and family feel like they are able to get answers to their questions. Without services like this, sometimes it feels like the patient and family are being bounced around to different locations without an answer to their question. Our fifth component is we provide education and training on self and family management and brain injury coping skills by phone or Zoom. This is actually our largest component that we do on a weekly basis. And in the next few slides, we'll provide you with more information on the education that we provide. And then our last component, number 6, is a warm handoff or referral to the state-affiliated Brain Injury Association. And this is so that at the end of the intervention, when the program is over, we can give the dyad, the patient and family dyad, a place to go to find additional resources. Some additional information about the program is that it is culturally and linguistically adapted. All of our materials are available in English and Spanish. We also recruit the patient and their selected care partner, which can be a friend or a family member, to participate together at the beginning of the study and ask that they participate together throughout the 4-month period. And then our program begins 24 to 72 hours before hospital discharge and lasts until 4 months after discharge. I have highlighted component number 1, the assessment of patient and family needs and referral to community-based resources in red, as this is our main component, making sure that we are finding a way to first and foremost determine the needs of the patient and family, and then find them resources to address those needs. This is also something that we will be discussing with you today, and so please remember this component as we'll discuss it in detail later. Our next slide, Maralise will discuss.
So as Dr. Oyesanya has mentioned, part of what we do is assessing the needs of the patient and the family caregiver. So we support the transition to home by starting with a needs assessment for the patient and the family dyads, 24 to 48 hours post-discharge. We're assessing the needs on a regular basis via phone or via Zoom. These are some of the examples of the needs that our patients have, whether they be physical, mental, assisting with community reintegration, healthcare needs, and follow-up care, as Dr. Oyesanya has mentioned, in accessing not just primary care, but also specialty care, vocational needs, and linking with opportunities for employment, cultural needs and equipment needs. We've had a couple of patients that needed actual equipment and going home, and then the actual needs of the family caregiver. And as we have found, and Dr. Oyesanya will mention later, we have family caregivers that are not just taking care of the person with TBI, but also another individual in the home, whether it be children or a parent. And so part of the process to gain resources and understand the community better, we have been working with our team and with community organizations in 4 different states, North Carolina, Tennessee, Virginia, and South Carolina, to really look at what resources are available and accessible for our patients and the family caregivers. And so we have created a community resource guide that our transitional care managers use as a way to begin the research process for what services are available in these varying states.
Thanks so much, Marilise. I'll also add that we are always looking for resources for our Spanish speakers. The resource guide that we have created so far is not comprehensive. In addition, we are actually a nationwide study. We don't limit our participants to having to live in North Carolina, Tennessee, Virginia, or South Carolina. They could actually live anywhere in the US. And so what this means is we're having to continuously search for resources in real time based on our participants' needs, as well as the location in which they live. We have been in contact with El Centro Hispano and have found a lot of really great resources. And we have also accessed the Latin 19 resource guide to find resources. But of course, there are still needs that are ongoing. And so one of the things that we'll talk about at the end is recommendations on additional resources to access as the needs are continuous, as you would expect coming home from a catastrophic injury like a traumatic brain injury.
And so previously, Dr. Oyesanya mentioned one of the, I believe it's number 4, which are our brain injury coping skills sessions. These are the weekly sessions that take place with the transitional care manager. And I personally love them because it gives an opportunity for the patient and the caregiver to learn about TBIs, but also equip themselves with information and tools necessary to care for the patient and for the family at the same time. And so patients who have had resources and support still have a gap around the education and training to understand traumatic brain injury and the impact that it has on the patient and the family. And so to address this gap, again, the TCMs include a weekly remote via Zoom opportunity to address a variety of brain injury coping skills. And there is a variety of topics. They're guided by self-efficacy theory. So their belief in their ability, their confidence in their ability to complete a task. And some of the proposed education topics include the consequences of injury, different types of communication, independence, safety, very centered around goal setting, stress management, alcohol and or abuse. Each session will be held on a weekly basis and begins within 1 week of discharge. So within the first 24 to 72 hours prior to discharge, they meet with myself. And if they're put into the intervention group with the transitional care manager, and then we begin the communication after they leave within 48 hours. And then 1 week of discharge, they begin their big sessions. And they will complete these until 4 months post-discharge. So for the patient, there are 16 sessions, as you can see, but the family caregiver has an extra 4 sessions that they do just with the TCM that helps them discuss issues such as stress and coping as a family caregiver and supporting people with with TBIs in their communication. And so the BICS education on caregivers and how it affects their loved ones and how to provide support while considering their own mental and emotional needs. And we have found that the participants have been very receptive to the experience of BICS and are eager many of them have been very eager to learn about I keep on saying transitional, their TBIs and how to take better care of each other.
Thanks so much, Marilise. I'll also add that although we have a total of 20 sessions, the first 3 sessions are in a fixed manner. So we offer session 1, followed by session 2, and then session 3. But all of the remaining sessions, we allow the patient and family caregiver to decide the order in which they would like to receive this education so that the education is delivered in an order that meets their needs. And so this is one of the ways that we personalize the intervention. And so as Marilise mentioned, the session 1 through 16, the patient and the family caregiver attend together. And then the 4 sessions at the bottom are for the family caregiver only so that they get some additional information on how to support the patient. So next, I would like to provide you with some information about the work we've done so far to test this program. So the testing of the Better TBI Transitional Care Program, the initial pilot testing occurred in 2021. We tested this in a single-arm, single-center study. We enrolled 31 participants, including 15 patients and 16 family caregivers. In terms of eligibility criteria, our patients with TBI were able to participate if they were age 18 or older, if they were admitted to Duke University Hospital for acute hospital care, and if they were discharged home from Duke University Hospital without inpatient rehabilitation. Their family caregivers or friends were also eligible to participate with them if they were age 18 or older, if they were selected by the patient to participate. And in terms of our findings, we learned from the pilot testing that the Better TBI Transitional Care Program was feasible, acceptable, and improved clinical outcome measures. And so what this meant was, from a feasibility standpoint, we were able to recruit people and enroll them into the study as we planned and collect data from them in the first 4 months after discharge. We, at the conclusion of the program, asked the patients and families their thoughts on the program, and we found that the individuals who responded to our acceptability survey, that they had a high positive experience, rating it a mean of 9.25 out of 10. We also found that our program improved clinical outcome measures. In particular, the patient's physical quality of life was shown, the scores improved significantly over time, a 31.36 point improvement over a 4-month period. This pilot test was also very helpful because we learned a lot of lessons. The most important lesson relevant to our talk today is that about 10% of our eligible patients could not be recruited because of language barriers. So what this means is we found that about 10% of the patients that were able to participate in the hospital were Spanish speakers, many of them living in the Durham or Triangle area, but we could not recruit them as we had initially planned because we had not yet built capacity to enroll Spanish speakers. We had initially intended to enroll Spanish speakers, but we learned that significant preparation was needed to be able to translate all of our study materials to Spanish, as well as to locate, hire, and train bilingual transitional care managers and study staff. And so to address this issue, we actually spent the last 3 years building capacity to enroll Spanish speakers. We have several team members that are pictured here, some of which are on the call today, who dedicated a lot of time and energy to translating our study materials from English to Spanish and helping us with cultural adaptation. And so we did forward and back translation. We reviewed our finalized translations and entered those translations into REDCap, which is a survey program. Here's a little bit more detail on the work that we did for cultural and linguistic adaptation. In the first phase, we translated over 400 pages of study materials from English to Spanish. This included our consent forms, participant workbooks, recruitment materials, and data collection scripts. After that, we secured about 15 Spanish versions of our data collection measures. And for the data collection measures that were not available in Spanish, we translated them ourselves. From there, we obtained feedback on our translated measures from native Spanish speakers before finalizing them. And then we also conducted focus groups with Spanish-speaking patients with TBI, family caregivers, healthcare providers, and interpreters to obtain guidance on how to culturally tailor our program to meet the needs of Hispanic and Latino patients and families that speak Spanish. I would also like to give a shout out to our co-investigator, Dr. Stephanie Ibemere, who made a valiant effort in overseeing, guiding, and leading our team in cultural and linguistic adaptation. Thank you so much, Dr. Ibemere, for all of your hard work and efforts. In addition to the cultural and linguistic adaptation, we also work to expand our team of Spanish speakers. All of our Spanish-speaking team members are listed here, and the grant that we received has allowed us to have more Spanish speakers on our team to guide this work. And this list also includes people who are bicultural. All of the work that we've discussed so far has informed our team's efforts to obtain a grant from the National Institutes of Health called an R01. And I'm pleased to be able to share that last year we had the R01 funded by the National Institutes of Nursing Research. We received $3.5 million to test the effectiveness of the Better TBI Transitional Care Program here at Duke. And so I'd like to share with you a little bit of information about the grant that we're currently doing, the study that we're currently doing. And so the purpose is to test the effectiveness of Better compared to usual care on patient quality of life by 4 months post-discharge. We are currently testing the program at Duke University Hospital. As we have proposed in the grant, we are aiming to recruit a total of 436 participants over the total 5-year award. This equates to 218 patient and family dyads per arm. In order to be eligible to participate, you have to be English or Spanish speaking. For both the patients and family caregivers, you have to be 18 years of age or older. Our patients have to be admitted following a traumatic brain injury to Duke University Hospital and plan for discharge home from acute hospital care without inpatient rehabilitation. And similar to our pilot study, family caregivers are also eligible to participate, and all individuals have to live in the USA. We are currently recruiting by invitation only, and the ultimate goal of this work is to decrease racial and ethnic disparities in TBI transitional care. As we are working to improve health equity, we are wanting to generate new knowledge that would help to advance the science so that we can give every patient with TBI and their family a fair and just opportunity to be as healthy as possible, regardless of the language they speak, their race, their ethnicity, so on and so forth. And so we'd like to share with you some progress on the study to date. As I mentioned, the grant began last year in May of 2023. Over the last year, we have been very busy. We have hired and trained multiple staff members. We opened for recruitment in January of this year. And to date, over the last 4 or so months, we have recruited 42 people from Duke University Hospital. This includes 26 individuals who are Black, 10 who are white, non-Hispanic, and 6 who are Hispanic or Latino. And the 6 who are Hispanic or Latino are also Spanish speakers. So 6 of the 42 are Spanish speakers. So one of the main things we wanted to talk with you about today is addressing the needs of Spanish speakers. Our main goal of the study, as a reminder, is that we are referring patients and families to community-based resources and services. But in attempting to do that, we have encountered many challenges to date. First, many of our Spanish speakers have low or no insurance. Many of them are uninsured, which makes accessing community-based resources and services difficult. We are working to develop trust and rapport with our Spanish speakers. We have also encountered Spanish speakers that, in terms of documentation status, that might be undocumented. All of these issues together have made it challenging to find resources. There are also limited resources available in the Triangle area in North Carolina for Spanish speakers, and even fewer for undocumented individuals. In particular, we have run into issues with finding resources for rental assistance, access to health insurance, access to specialty care, especially for our patients who do not have insurance. And then another challenge is that although sometimes resources are available, our participants are unable to complete application forms to receive those resources online, and they're actually having to go in person to complete them, and they're not able to complete them over the phone either. And so we come to the group with some questions. We would like to know what recommendations you have for us. First, on finding and accessing community-based resources and services for Spanish speakers, especially those who are undocumented. We have been working with El Centro Hispano. We have accessed the resources Latin 19 has put together, but there are still many needs that we are working to address and would love any guidance, recommendations, or suggestions that you have for us. Another question we have is any recommendations on developing trust and rapport during a vulnerable time, especially with our Spanish speakers. Again, the patient has recently sustained a very severe injury, a traumatic brain injury, and is going home and trying to pick up the pieces of their life and find a new normal with their care partner. This can be a really challenging time. In addition, discussing documentation status is something that is a sensitive topic. We don't ask directly about this. We also don't record this information in the study. And we have used a variety of different strategies to try to put our participants who are undocumented at ease to know that they can trust us and that we're not going to get them into trouble and that we're here to help. But of course, we would love to take this back to the community and ask for some additional suggestions from you all on how to address these issues. And so that completes our presentation. I do have a slide thanking you all so much for listening, asking if there's any questions, and our contact information is here as well.